Welcome to this class on maternal movement and positioning for labor and birth. My name is Dr. Elaine Zwelling. I've been an OB nurse my entire career, first as a labor and delivery nurse, then as a professor of OB nursing. Most recently, I've been a clinical consultant for several companies, and I'm also an author of an OB nursing textbook and a number of articles in perinatal nursing journals. I'm pleased to have the opportunity to share information with you about the importance of using movement and position changes to facilitate your patient's labor progress, and also to give you ideas about how to use your Affinity birthing bed to do this. This class will cover 6 points. I first want to give you a brief overview of the research supporting movement and position changes for laboring women, so that you'll feel confident that your interventions are evidence-based. I recognize there may be some clinical challenges you face related to maternal positioning, so I'll identify those. I want to share 6 physiologic principles that will give you an understanding of the benefit of various positions in labor. These principles include promoting spinal flexion, promoting an increase in the uterospinal or pelvic drive angle, facilitating stronger expulsive forces, promoting a good fit between baby and mom's pelvis, increasing pelvic diameters, and facilitating occiput posterior rotation. Throughout the class, I'll be demonstrating the positions I discuss with you with the help of Stephanie, a pregnant mom in the Affinity bed. I'll review positioning options recommended for second stage labor and give suggestions for using your Affinity bed for positioning for shoulder dystocia. There have been many research studies in the past 50 years to show the benefits of upright positioning and regular position changes during labor. These benefits include the following. First, decreased pain. Studies have shown that pain can be decreased by the ability to move and change positions during labor. Upright positions are particularly helpful in this regard. Upright or side-lying positions are also best to facilitate maternal fetal circulation. The quality of uterine contractions has been shown in studies to be best when women are upright, most likely due to the benefit of increased gravity. Side-lying positions are also beneficial. A number of studies have found that both first and second stages of labor were shorter for women who were upright when compared with women who remained in a flat or semi-recumbent position. Fetal descent is promoted when upright positions are used and position changes are frequent. This assists the baby to find his best fit through the pelvis. And finally, studies have shown that women in upright positions have fewer operative vaginal deliveries, decreased perinatal trauma, and fewer episiotomies. But the realities of clinical practice today can make position changes challenging. We are definitely in the epidural era. When your patient has an epidural, it's more difficult to have her change positions. We also seem to be in an obesity era. When your patient is heavy, helping her change positions is more challenging. Of major importance in your nursing care is maintaining a good fetal heart rate strip. If the patient is being monitored externally, position changes may alter your tracing. And if she's obese, that challenge is even greater. Your patient may be reluctant to move. She may not understand the benefits to her labor of changing positions. so education is important. You have to be a saleswoman and convince her that changing positions frequently will be to her and her baby's benefit. The literature related to maternal positioning and movement suggests that laboring women should change positions every 30 to 45 minutes. This can be challenging if nurse staffing or time are an issue. Hopefully, you're staffed at A1's recommended 1 to 2 nurse-patient ratio so that regular position changes are possible. Let's now look at what positions to use that meet the 6 physiologic principles. The first principle is to promote spinal flexion. Spinal flexion means that you want the mom's back to look like the letter C, being curved like you'll see in the picture, rather than her back looking like the letter S, which puts it into a position of lordosis. The C curve can be achieved either in an upright or in side-lying positions. If the mom is lying on her back, even in a semi-Fowler's position, her spine and her uterus with baby are parallel to each other. There's no angle between them. As a result, the contractions will be directing the baby toward the anterior part of her pelvic inlet at the symphysis pubis. But if you sit her upright and have her lean forward, her uterus and baby will fall forward in her abdomen, now creating an angle between her spine and her uterus. Now the baby will be directed to the posterior part of the pelvic inlet, towards the sacrum and coccyx, the wider, roomier half of her pelvic inlet. You can achieve the C curve and this increased uterospinal drive angle in several ways. You can first begin by sitting the mom upright in the Affinity bed. The next principle is to facilitate stronger expulsive forces. Upright positions make use of increased gravity. Research studies done to measure the quality of contractions found them to be stronger, more efficient, and less painful when the mom is upright. There's psychological benefits of being upright as well, rather than always being supine. Upright positioning in the Affinity bed is achieved by raising the head all the way up, lowering the foot section, and we call this the throne position because then mom feels like a queen sitting up in her throne. There are 4 ways that you can achieve the C curve position of the back and increase the uterospinal drive angle. The first way is to have the labor partner sit on the foot section of the bed and then have mom leaning forward with her arms around his chest and resting on his shoulder. As you see, this gives the C curve and her baby and uterus are falling forward in her abdomen. A second way to achieve that C curve positioning and increase the uterospinal drive angle is to use your over-the-bed table. Put it in front of the mom, have a pillow on it, and then mom can just lean forward comfortably resting on that pillow, and you will see how that achieves that positioning. This is so comfortable in labor that many times mom can even fall asleep in this position. Using a birthing ball is the third way that you can help the mom achieve the C curve position and increase the uterospinal drive angle. Place the ball on the foot section of the bed between her legs, and then you can have her lean forward, hugging the ball. She can even rock back and forth with that ball, and again, you see how it gets her into that position so that the baby is being directed towards the posterior part of the pelvic inlet. The final option for achieving the C curve positioning is to use the labor bar on your Affinity bed. Place the bar on the bed and then use a pillow over the top of the bar so that mom can sort of lean forward on that pillow, resting her head and almost dangling from that bar. You see then that this also gives the C curve of the back and allows the baby to fall forward in her abdomen. To promote a good fit between the mom's pelvis and her baby, one of the things that helps is to rotate her position every 30 to 45 minutes. So I'm going to demonstrate a 3-position rotation. We would start Stephanie out sitting in the throne position, and then I'm going to lay her back and turn her on her side, and we'll have her in side lying position for about 30 to 45 minutes. So Stephanie, if you want to turn over on your side, and remember, even when she's on her side, you want to be sure her back is in that C curve. So I'm going to have you bring your pillow forward, and let's get you a little more forward this way so her back looks like the letter C. Then, for comfortable side lying, make use of the calf supports on your Affinity bed. Bring them up just as you would for the delivery, and her upper leg is going to come up then into that top calf support, and her lower leg will be on the flap of your foot section, which when you fold over becomes a pillow to support her upper leg. This then is very comfortable positioning. What you want to do is raise that calf support by pressing the button on the side rail to raise the foot section as high as is comfortable for the mom. You want the upper leg as far away from the lower leg as you can get it in order to open the transverse diameter of her pelvic outlet. Is that comfortable? After your patient has been on her side for 30 or 45 minutes, then what you can do is get her back into the throne position. And remember, throne position, you're going to raise the head of the bed all the way up, foot section all the way down. And from this throne position, if you leave her in this position for 30 to 45 minutes, remember your 4 options for getting her to lean forward to achieve that C curve of her back and increase the uterospinal drive angle. You can put her labor partner on the foot section. You can put the birthing ball on the foot section between her legs. You can put the over-the-bed table in front of her with a pillow, or you can put your labor bar on the bed and have her lean forward on the labor bar. So we'll keep her here 30 to 45 minutes, and then we're going to turn her over to her left side. The next principle is to increase pelvic diameters. Because of the woman's hormones during pregnancy, her pelvis is movable. If she remains in the semi-recumbent position, her sacrum and coccyx are locked against the mattress, preventing an increase in the anterior to posterior diameter of the pelvic inlet. By sitting the woman upright, the sacrum and coccyx can now move back during a contraction, thus increasing the anterior to posterior diameter. When sitting upright, the downward weight on the ischial tuberosities causes the pelvis to open up transversely, thus increasing the side-to-side or transverse diameter of her pelvic outlet. The final principle is to facilitate occiput posterior rotation. Using strategies to help an occiput posterior baby rotate to the occiput anterior position can greatly affect the labor outcome. If you know that the baby is an occiput posterior and you want to try to help the baby rotate to the anterior, there are several positions you can try to accomplish that. One is to take her from straight side lying, as I demonstrated earlier, into a side lying lunge. Use your birthing bed to do that, and also have the mom take her lower arm and place it behind her using the pillow to give her support under her chest and head. Then bring the calf support out in this fashion. And what that's going to do is rotate the mom forward. You'll have to readjust the calf support so that it's comfortable for her. And by rotating her out that way, her lower leg will be a little straighter, and as you can see, gravity will help the baby to rotate to the anterior. Another position that most nurses are very familiar with that you can use to rotate a posterior is to have mom get on hands and knees. You can have her on the foot section of the bed, and remember your Affinity birthing bed holds 400 pounds on the foot section, so you don't have to worry about placing her there. You can then have her lean over pillows, as you can see that Stephanie is doing. Or another way to do this same thing is to raise the foot section up equal to the seat level of the bed, and instead of pillows, have her use the birthing ball under her as she is on all four positions. With the birthing ball, she can rock back and forth a bit. Either way, with pillows or with the birthing ball, this is a great position. Obviously, in order to be able to do this, the mom has to either have no epidural or have an epidural that's low dose enough that she has weight-bearing capability on her knees. The last position that I'm going to show you to try to rotate a posterior baby is to have her kneeling in the birthing bed. You'll see now that she's kneeling on the seat section. The back of the bed is raised all the way up, and Stephanie is sort of draping herself over the back of the bed with a pillow. Most moms find this to be very comfortable. Another thing that can be used when she's in this position is counter pressure. Dad can be rubbing her back and giving counter pressure if she's having back pain. This position again can be used if she either has no epidural in yet or if her epidural is low dose enough to allow weight bearing on her knees. Now we'll discuss positioning for second stage labor. Continue to do the 3-position rotation that's been demonstrated until delivery is imminent. With an epidural, begin active pushing only when the head is visible on the perineum. Once the mom is ready to begin pushing, you can use your Affinity birthing bed in several ways to accomplish that. Put your labor bar on the bed and begin her pushing with her sitting upright in the throne position, grabbing forward on the bar. This is called a seated squat. Because she has an epidural, she can't actually support her weight and squat, but she can sit. And so she will be pulling back as she's pushing down in order to accomplish pushing from this position. Once the baby has descended to a lower station, you can then have the mom in a more semi-reclining position, and with the labor bar in place, use the towel pull. This allows the mom, who has an epidural and may have no sensation, to get that feeling of pushing as she's pulling back on that towel. You can have her position so that her feet are on the foot section of the bed, or you can have her bring her feet up onto the labor bar and push in that position. If she has an epidural and she's having difficulty keeping her feet on the bar, her partner and a nurse or another family member can stand on either side of her and just support her feet against that bar. This is a wonderful position to bring the baby down under the symphysis pubis to be ready for birth. Once the physician has arrived and the head is visible at the pelvic floor, then mom can be put into the calf supports. Remember to raise the hand grips on the bed for her to use to pull back on as she's pushing, so that she's in a comfortable position for the delivery. The complication of a shoulder dystocia requires rapid positioning using McRoberts position. These 4 steps show how to use the Affinity birthing bed to assist in managing this complication. H is for help. Immediately call for assistance. E, elevate the mom's legs into McRoberts position. L, Lower the head of the bed by pulling the CPR release located on the side of your Affinity bed. P. Push the seat inflate button on the side rail and employ suprapubic pressure. One of the ways that labor nurses can injure themselves is by holding patient legs. By using the calf supports on the bed, as shown in the picture, this injury can be prevented. As the baby is delivering, if the physician announces a shoulder dystocia, you're going to want to use your Affinity bed to get her into McRoberts position as quickly as possible. The first step would be to get her flat fast, and so I would use your CPR lever to do that. After she's flat, take her soles of her feet and put them against the back deep lip of the calf support. Obviously, if she's had an epidural, you're going to need someone on either side to hold her feet against these calf supports. But with this position, you can see that puts her clear back into McRoberts position, and it's the bed that's holding this weight, not your body. Studies have shown that the #1 way nurses are injuring themselves is holding legs, whether for McRoberts position or for second stage pushing, so use the bed when at all possible. There is a great deal of evidence in the literature supporting the clinical practice of keeping laboring moms upright and changing positions frequently throughout labor. Despite the fact that there may be challenges in achieving regular maternal position changes, these challenges should not prevent nurses from including this as part of their nursing care plan. The positive effects that can result for your patient will be well worth the effort.